All right. Thank you, everyone, for joining us tonight. I am Nick Hartog, and we're joined tonight by Dr. Steve Holland to go over a case. And we're the only case tonight, and so we'll have plenty of time for discussion. So throw out any questions as we go along. I'll be monitoring the chat because I'm doing the presentation and monitoring it too tonight. So what we're going to start out with is something that we've started with the ECI committee at the beginning of these, is just a quick review of an article that was published recently that we find interesting for whatever reason that we wanted to make sure it gets out there. And so this was an article that was in preprint earlier this summer, but actually just went to print the last Jackie this last month. And it's looking at granulomaspecific interstitial lung disease, and it's a retrospective review of 39 patients at one institution, the Medical College of Wisconsin, looking at their treatment with combination chemotherapy. And they had put out this treatment that's really been, for a lot of ways, the standard of care or big treatment for GL-ILD, but the original paper is only about 9 patients. So this really does add a lot to the literature as far as more patients treated this method. So what they did, they got a retrospective review for about 12 years, and they found 39 patients that they had treated. They had a high-resolution CT scan before and after therapy. They had radiologists blindly score the CT scans. Then they also had pulmonary function tests, lymphocyte subset, analyzed before and after, and this was just part of their standard care as it was a retrospective review. Then they had whole exome sequencing performed on some patients. That was people that they thought it was clinically indicated. Then their combination chemotherapy, they gave rituximab weekly for 4 weeks, every 6 months for 3 to 4 rounds. Then they either went with azathioprine, which is what they started out on a daily basis for an average of, I think it was about 16 months, or MMF, and that was mainly for the people who didn't tolerate azathioprine. And everybody, in order to qualify, needed a CVID diagnosis, and they used the standard diagnostic criteria there. They were screened for infection to rule that out at the time of lung biopsy, and so they did cultures of the biopsy. And the various biopsies they did is most of the patients had an open lung biopsy. A couple had transbronchial, and then one had a mediastinoscopy. Oh, good, people are getting sound. At least Rebecca Marsh is, I'm hearing. Perfect, okay. And then one was just diagnosed clinically. They had a biopsy somewhere else, and then the high-resolution CT scan was consistent with it. So we look at they also had an age-matched people with CVID, and they had a lot of similarities between it. And these people with GL-ILD were 36 years old, and average 6-7 years from the onset of their CVID diagnosis. The big difference between the general CVID and the GL-ILD was there's more cytopenias, splenomegaly, nodular regenerative hyperplasia in the GL-ILD, which isn't completely shocking. One thing to note is when we look at the lymphomas, that there were 3 MALT lymphomas with when lung was primary, and that was diagnosed on the biopsy for GL-ILD, and so that, for me, just underlies the importance of needing to get a biopsy before proceeding with therapy. And then they also, I should say, with the therapy, had somebody on at least 6 months of IVIG before they made the decision. So then if we look, they had substantial high-resolution CT scan in the vast majority of patients. 8 patients had various monogenetic defects identified. And then there's a sustained remission in 75% of people. And then the people who relapsed, it was a median of about 3 years that they relapsed. Then we look at, they had a lot of improvement in FEV1, FVC, and TLC, but it did lag, and they didn't have as marked of an improvement as with the radiographic improvement. Treatment was well tolerated. But one of the things is it really is unclear when to treat a specific individual, whether we wait till they have symptoms, whether we wait just anybody with a diagnosis, do we wait till their FEV1, their DLCO goes down, and those are some of the questions I think remain to be answered as far as this. And then it is effective in patients with and without a monogenetic defect. I think that was one of the big things that came out is, I know at least in my head, when we get things like CTLA4 haploinsufficiency, the thought is, should we treat them a little bit differently? But they did not and had similar results. And this example is actually a patient with CTLA4 haploinsufficiency with their lung disease. Then they also had these infiltrates and white matter changes in their brain, and that did also recede with the combination chemotherapy. All right, so now we're on to the actual case. And this is a patient with, as you get, COVID and pancytopenia. So this was a 29-year-old male who presented to a regional ER in the area in November, or should say 2020, sorry, November. He had a Tmax of 39. He had cough, body aches, headache, loss of taste and smell, vomiting, diarrhea for 3 to 4 days. So a story that if you've managed any COVID patients, we've heard a lot of. And he also walked in the ER during the midst of our peak locally. And so basically anybody who came in with that for sure had COVID. And he had no known sick contacts. They got a CBC that showed some significant findings with a white blood cell count of 1.7. His hemoglobin was 9.3. His platelets were 144. And when they talked to him about it, they documented, he kind of shrugged his shoulders and said, that's similar to what I was told in Pennsylvania a few years ago. It's not a big change. They did a COVID PCR. It was positive. He was not in any respiratory distress, was not in any oxygen, and he was discharged home with azithromycin. Then the next day, he came back with worsening shortness of breath. He did not pick up his azithromycin, and they, at that time, his Tmax was 39 degrees, and he had a pulse ox of 92, and his pulse was, and he was tachycardic. He then desaturated during the ER stay to 87%. They had to put him on 2 liters of nasal cannula in order to keep his oxygen sats above 90%. And that was really the trigger that made him get admitted at that time. So then on admission and on the ER, they got further labs, which showed a white blood cell count there still decreased. And his hemoglobin was 7.7. His platelets were 114. Because of this, they got a peripheral smear that showed marked anemia without schistocytes or spherocytes, leukopenia, some reactive changes, no blasts, and just not enough platelets. Then because of this, they got some iron labs that showed a little bit high iron. His iron saturation was a little bit low. His iron total was a little bit low. But then B12 and folate were normal. His CRP was elevated, and his procalcitonin was also elevated, and blood cultures were negative. And so one of the first questions I want to say, if anybody has any input, is when you look at these labs, are they all that abnormal for the average person you see who's admitted to the hospital with COVID? No. Pause a second if anybody has any input or anything that jumps out at them. So yeah, somebody did notice that the monocytes were absent in this patient. And a couple people are that not typical to have anemia, and that's I would say correct, is that that has not been well documented, and that the CRP is a little bit higher than we usually see. But one of the things, and the pathologists didn't think a ton of it because they have been seeing a lot of thrombocytopenia, a lot of minor anemia, but not this significant. So then when we get a little bit further history, and somebody just added that his all lineages are low, which is a good point and something to draw out. That he works as a roofer, is that he grew up in Pennsylvania Amish community, and he moved to Michigan about 1 year ago with his wife and children. And his pancytopenia was noted about 3 years ago. It was worked up in Pennsylvania, and he's not really able to tell me much about that. Somebody wanted to do a bone marrow biopsy, he didn't let him. And he thinks his anemia was present since about age 17, that alone, but he's not for sure about that. He was admitted to the hospital in Pennsylvania about 2 years ago with what he describes as extensive herpes simplex. It was mainly in the mouth, but it also was on his skin a little bit and on his face a little bit. And then he also had warts on both hands that extended about midway up his arm. So when we look at his physical exam, he's a normal-sized guy with a BMI about 34. He is ill-appearing at this time. He's tachycardic. He has some crackles in the base, and he's got some epigastric tenderness, but otherwise unremarkable abdomen. And he's probably got about 30-ish warts on each hand, extending up to his elbow bilaterally. What are some people's thoughts at this point hearing this story? So the family history, we'll get to that on the next slide. So I'll hold back on that. And then somebody's thrown out GATA2 deficiency as a possibility. And Rebecca Marsh is saying Amish, so considering cardiovascular hypoplasia. And Rebecca, I'll tell you, that is exactly where my mind went. Then we have hypomorphic IL-2 deficiency. So when we look at this, and we look at his family history a little bit, the Amish background would suggest autosomal recessive, especially when we look at his family tree. And we have both of his parents are first cousins, and him and his wife, second cousins, and him and his wife are also second cousins too. And then we look, he's got a lot of siblings with some history. One that was an 8-year-old that died of leukemia and disseminated varicella, a 25-year-old who died of a leukemia, a 12-year-old sister who died of leukemia, and a 17-year-old sister who died of leukemia, and one sister who has lymphedema but has otherwise been well. And his dad had warts, and all 3 of his sons are healthy as far as he knows, but they're all under 10 years of age right now, but haven't had any significant issues. But they also haven't had much interaction with the medical system at all, but nothing he's felt the need to take them in for. All right. So we had a little bit more labs. And with those labs, we had basically all of his lymphocytes were low. And yes, the BMI of 34 is normal in the Midwest. And then his immunoglobulins were all normal. He had an undetectable IgE, and his strep pneumo response was normal at baseline. He had never been vaccinated, but that was just his baseline normal strep pneumo vaccination. All right. So the remainder of his hospital course, he got IV remdesivir for 5 days. He got dexamethasone, and that's pretty standard treatment in our hospital at that time. He never got above 4 liters of nasal cannula oxygen, and he was discharged after 5 days. So any additional thoughts or things that people want to add as the next slide gives us the diagnosis at this point? So one thing bringing up is looking for the NK bright and dim, the CD56 bright and dim. And unfortunately, at our lab and our flow, as much as I twist the arm of our hematopathologist, they're not able to do it. The antibodies are tied together, the 16 and 56, so we don't have those. And yeah, the family history was very concerning, which is the reason I was consulted and got involved. And so we did genetic testing at follow-up, which did reveal, as many people have thrown out here, is a GATA2 deficiency. It had not been revealed or described before, but it is upstream of the C-terminal zinc finger, and it has not been reported in exact at all. So. And with that, with GATA2 deficiency, it is critical for the function of hematopoietic stem cells, and so much so that homozygous knockout is lethal, and that it was really identified in 2011 as an explanation for 4 different clinical syndromes, One is the monocytopenia and mycobacterial infections, which somebody pointed out his monocytes are 0, and that's absolutely true. Dendritic cell, monocyte B and NK cell deficiency, the familial MDS and AML syndromes, and then Emberger, which is the lymphedema and myelodysplastic syndrome. Most of the defects are in the C-terminal zinc finger or the null upstream variants, which is what we had in him, splice site or intron region variants. So when we look, there's really a lot of different things that GATA2 deficiency can do, including PAP, and then we have the warts, we have the lymphedema, we have sensory neural hearing loss, but then we look at the hematologic manifestations. It is MDS, AML, CMML, NKB, CD4 lymphopenia, neutropenia, monocytopenia have all been described in this. Then we look at the infectious side, a lot of different viral, mycobacterial, fungal, and bacterial infections. And specifically, the viral are HPV, recalcitrant warts, the severe herpes virus, which we saw in this patient. His brother had the severe varicella. We can have some EBV and CMV issues, disseminated non-tuberculosis mycobacterial, and then various fungal infections can also be seen. When we look at the manifestations, the onset of illness really tends to increase over time. There are asymptomatic carriers, but the later and later you go on in life, the less and less that happens. When you get into the 40s, most everyone has some kind of manifestation at that time. And the onset of the MDS or the leukemia, again, increases with age. Same thing with the mycobacterial infections, HPV, and bacteria, and all the other infections. That really, they will appear some in childhood, but once we start getting late teenage years, 20s and 40s, a lot more of the manifestations start to show up. And as somebody pointed out with the CD56 bright and dim, is that this is a cause of one of the, as Steve also said, original NK cell deficiency. And this is the paper describing that, that showed an absence of the CD56 bright NK cells in patients with GATA2 deficiency. Then when we look at survival, overall survival, again, really is pretty good in childhood, but once we get to adulthood, it starts to drop off more and more. And a lot of that is because of the development of the more manifestations, the more cancers, and myelodysplastic syndrome. And then when we look at people who have been bone marrow transplanted, this is at the top people who have been transplanted under the age of 18, and then people who have been transplanted between 18 to 35, and then after age 35. And so the longer you wait to do a bone marrow transplant, the worse the outcomes are. And so with management, really it's controlling the infections, managing the pulmonary disease. We want to vaccinate against HPV and malignancy monitoring, including pap smears and any different HPV cancers that can develop. Hematologic monitoring, and some people recommend monitoring this like Shwachman-Diamond syndrome or the other bone marrow failure syndromes where you may get a yearly or every 2 years bone marrow biopsy. And hematopoietic stem cell transplant really is the only curative treatment. Then one of the things is really what should be the trigger for it. And so in conclusion, before we kind of bring in Steve here, is GATA2 deficiency is essential for hematopoietic stem cell transplant. It is a familial cause of the AML, MDS syndromes. And it is cause of monocytopenia, NK cell deficiency, and hematopoietic stem cells transplant can be curative in this. So Dr. Holland, I wanted to start first off with how do you handle the monitoring of the hematologic manifestations and the decision as far as when to transplant patients like this?
Yeah, well, thanks for coming up with the easy questions first, Nick. Let me just say, I think this is a very instructive case. A guy comes in for something that is common, COVID, and then astute clinicians notice that not all of his manifestations are common. Of course, it would have been better if astute clinicians had taken a family history before he showed up in the ER. I think that point that many people picked up on, he's coming from an Amish background, and yet he has an absolutely non-Amish disease. All of these are reminders to keep your differential broad. This issue about when, how do you prophylax, how do you monitor, and then when do you transplant is a very dicey issue. And because there are no good data, that gives people like me a chance to jump in with what we've got. And I think, as you so clearly pointed out, Nick, the problem with this disease is that early in life, usually it's pretty okay. Now, there's some caveats there because a lot of these kids show up with monosomy 7 and MDS in childhood, but that's a slightly different manifestation than what we're talking about here. Most of these people with this kind of GATA2 deficiency are fine until they get into adolescence. And so up until that time, I don't think there's a whole heck of a lot to say except to make sure that you get a CBC at least every year. And if things start to change, get a CBC and immunoglobulins. There's certainly people who can present like CVID and can lose their immunoglobulin levels earlier. But I think I'd get a CBC and immunoglobulins until they get to be, 8, 9, 10. And then somewhere in there, I really think they need a screening because they're definitely children who develop MDS and leukemia, just as you saw in that family tree. For my approach is that as soon as they start to have hematologic abnormalities, especially B cell or monocyte declines, I start azithromycin daily prophylaxis for adults or big children. I use 250 milligrams. Why do I do that instead of what you use for pneumocystis? Because it's not pneumocystis and they don't have HIV. How do you decide how often to do marrows? Once a marrow is abnormal, then I think at a minimum, you probably need to look once a year. It's very important to make sure that you send off the genetic testing, the heme malignancy sort of panel on each of those marrows to detect the accumulation of either cytogenetic changes or genetic mutations that conspire with GATA2 to really lead to leukemia. I can't emphasize enough that the leukemias that develop in GATA2 deficiency are way worse than the leukemias that come up spontaneously. They're harder to cure and they are more difficult to treat. And then, what to do. The other thing to make sure to mention is that they ought to get HPV vaccination. Should start that at a relatively early age. I think it's approved for down to age 9. And I would certainly do that. They're not, the big issues with the warts, of course, there's the unsightliness. And then in females, the vulvar and the cervical disease. And in males, we've seen several penile carcinomas. So you really want to start trying to give them HPV vaccination early. Can I prove it works? No. Can I tell you that HPV is bad in these people? Absolutely. And I think those are the main things. The other thing, this guy well illustrates the problems of primary herpes virus infections. He had oral disease. We've had several people get HLH in response to their primary either EBV, CMV, or HSV infections in adolescence or adulthood. That can be quite severe. So you want to I think it's a good idea to get the serologies early on. If they're already seropositive, you've dodged that particular bullet. But if they're not, it's something to keep in mind if they show up with a protracted fever and, other problems. So I think I'll stop there.
And then, Steve, one of my follow-up questions too is one that I know a lot of us are struggling with right now is the individual risk factors for each of our patients with immune deficiency for COVID. And so when you think about this and you see the course that he had with COVID, is that kind of what you would have expected in a 34-year-old to have a little bit of trouble, or is that unexpected?
I think, GATA2 deficiency is, it's a funny disease. There's no question that influenza can be much more severe in GATA2 deficiency. People die early on, and I think I approach this like influenza. And I think his response is, I mean, there are certainly other 34-year-olds who get in trouble. I think GATA2 is probably a condition in which COVID is more likely to be more severe than in some other immunodeficiencies. So I would have a medium to high level of anxiety for this. Luis asks, have we found anti-type 1 autoantibodies in these patients? No, but we haven't had that many of them. And we'd be happy to look if you've got GATA2 patients that are having problems. We've just not seen too much in the way of autoantibodies in these patients yet, but I can't say that we've tested them as extensively as we probably should.
All right. Any other questions out there right now?
So one question is, I mean, this guy sort of fell through the cracks, right? In large part because he wasn't interested, because he felt fine. And people had done, I noticed that you said he had a workup in Pennsylvania for his pancytopenia. And I have an idiosyncratic view here. I think we could all spend a lot of time getting antibody levels and flow cytometry and even bone marrow testing, but sooner or later, it virtually all leads back to getting a genetic test. And with some of these PID panels from companies now eminently affordable, I suspect way cheaper than doing a bunch of flow and antibody testing, I would think we ought to do that just right off the bat.
And
Well, I don't
that's
know how other people.
Oh, I was gonna say that's a good point, and it especially came up in this patient as he is from the Amish community where he's cash pay, and so every test that we do that's expensive was coming out of his or his community's pocket, and so we ordered one test when he came, and that was a genetic panel, and so that was actually the only test I have on him. He's scheduled to follow up in his kids in actually 2 weeks, but as of now, that's the only post-hospitalization test we got.
Well, that was very wisely done. And where did you send that test?
To Invitae, and then we actually used our Jeffrey Modell free test too, so it was free to him also.
Yeah. So, and I think, as Rebecca points out, $250 for a PID panel is really an extraordinary opportunity to now get 407 genes. And I think, the problem with most of the functional testing is that when you get the answer, then you're going to press for the genetic test to confirm it. But honestly, the functional tests are difficult to do, and I think especially in the setting of acute illness, as you asked in your first slide, how do you know what's appropriate in the setting of acute disease? And if you're not sure if you're not sure how acute disease is going to influence your functional test, it makes it very hard to think that that'll be reliable. So I think you did exactly the right thing, and I can't imagine many tests that are cheaper. It's pointed out that the tests don't cover the deep intronic regions. That's absolutely true, and I think that should be a lobbying effort to Invitae and other companies to put in the well-recognized regions. There's only one important intronic region for GATA2, and it accounts in our series for about 25% of individuals. So it's a shame to miss that. And I think that that could probably be done pretty well. One of the advantages to these panels, as opposed to, say, a whole exome, is that you get a much deeper read so that you can pick out deletions on one allele, which for haploinsufficient genes could be very important.
And then I just see the question about how to evaluate his sons, and so that's who I'm seeing in, I think it's 2 weeks now, is his three sons. And the nice thing about some of these companies now is that once you get a positive test, they will test family members for free within, I think it's 150 days I have. And so we're able to get
Right.
that now extended family testing for free.
As long as it's a recognized family risk gene, that's absolutely right. I think they're reluctant to do that for research things, but here you've got an absolutely straightforward mutation and a straightforward syndrome, and I think they would be. This is a perfect use for that.
Yep, and they say in their report it qualifies, and so they offered it before we even had to ask.
Yeah, and so Anthony points out that insurers are very reluctant, and I agree. And all I can say is that occasionally insurers really do just live up to our expectations, but then sometimes they do exceed them. And I think if you could explain to them, look, I could do this incredible flow panel and all of this antibody testing and a bone marrow, or I could do a $250 test. Most of them will sort of get it if you can lay it out to them. But I know that's extra time. One of the things that Kathy asks is about evaluating his sons, and I think I would argue that you do the genetic test first, and then if his sons are affected, and it's certainly likely that at least one of them will be, then, if they're 10 years old, I would at least look very hard at whether they need further intensive investigation, like a bone marrow and some other serologic testing. I think these are, as you saw from his siblings, this disease can take its toll early in life. And with a chain terminating mutation like this nonsense change, those are the people that have the most severe disease. You saw the one sibling who had lymphedema. I promise you she's headed for problems and should be investigated and probably transplanted ASAP. And then the other ones who have not been tested, who have not yet gotten sick, should be looked at. One exception I'd like to take with the Donadieu paper in the French pediatric group is not so sure that the age differentiation that they show has been maintained. And I think that deciding when to time a transplant is very important. And there are a lot of things that go into it. Are they old enough to have eggs or sperm harvested? Are they old enough to get out of college and to be able to take time off? Or, the many, many things that happen. I don't think that we've done now about 75 transplants, and I don't think we've seen age as a terribly important cofactor in survival. The critical things that we've seen are the quality of the match, the use of post-transplant Cytoxan, and the presence of leukemia going in. The things that surprisingly haven't been such a big risk factor, lung disease gets better with transplant, infections get better with transplant, the warts get better with transplant, even a lot of the cervical and vulvar dysplasia gets better with transplant. So I think, what would be the triggers? They would be progressive illness in any of those spheres. And for some of our young women patients who have had very disfiguring genital surgery, this is really a key step to making sure that they don't need more. And I think the restoration of probably NK, but also some T cell function really makes a big difference. Yeah, Harry points out you got to know the genotype of other family members in terms of using them as donors. Oh man, is that ever true?
Yeah, and with his family, he's actually the only ones that have made their way to Michigan. Everyone else is still back in Pennsylvania.
Well, we're close to Pennsylvania, and we're more than happy to help out here. And the charge is quite tolerable.
That is good. I've been pushing it, so I'll push him that way when I see him.
And we're happy to see them, and we've got a very big transplant program, and can do all the testing and everything else. So we'd be happy to do it. One of the questions that's raised here is about a future role for gene therapy. Yes, I'm sure there is a future role for gene therapy, but I don't think we're quite ready for it yet for this disease. GATA2, it depends. If you were talking about, say, a CRISPR repair, that would be attractive. One of the problems of gene therapy for this disease is that if you don't get absolutely complete elimination of the GATA2 mutation, you might have the risk of having a clone emerge in the future. So I think for now we need both the anti-leukemic effect of the transplant as well as the immune restorative effect. I don't doubt it may happen in the future, but probably not quite yet. A question about, does this fix the lymphedema? Damn, I wish it did. And I have crossed every possible finger and toe, hoping that would work. And so far, I'm not really persuaded that it has. I think it has helped some people have less cellulitis around their lymphedema, but I can't say that I really think it's made the lymphedema itself go away. What kind of conditioning do we use? If you look, the papers are by Dennis Hickstein. We use busulfan and Cytoxan, and then some TBI. And then it depends a little bit on what the donor is. And then really the big issue for us is the post-transplant Cytoxan. 2 days of high-dose Cytoxan on days 3 and 4 post-infusion really has made an incredible difference in the rate of GVHD. And it really is very effective. John Ziegler, who's concerned about the BMI in the United States. Thank you, John. And I wish that Nick were right, that it was just a Midwestern problem. So what's the mechanism for the lymphedema? It turns out that GATA2 is expressed in the lymphatic epithelium, endothelium. And it's really, GATA2 is also a vascular factor. It's absolutely fascinating. As Nick pointed out, if you've got a complete knockout of GATA2, hematopoiesis doesn't even begin, and the animals die. They're sort of pale embryos that never achieve normal blood mass. But if you have a hypomorphic variant, something that, say, is working at 20 to 30% of normal, and you only have 20 to 30% of normal GATA2 expression, it's enough to get you through hematopoiesis, but it's not enough to get vascular formation right. And so those animals, whereas the complete nulls die at about embryonic day 9.5, the hypomorphic variants die at about day 13. And there, they actually die because of vascular disruption, and they leak blood throughout the embryo. It's quite striking in the pictures. Now, the lymphedema, it is certainly more common, I think, in those who have a chain-terminating mutation, like what was described in the Emberger syndrome. But Amy Sue in our lab has been putting together our more global experience, and I have to admit that there is lymphedema with many of the mutations, and it's not quite as closely linked to the genotype as I had thought. So the mechanism, I think, is abnormal expression of GATA2 in the endothelium. Why that leads to lymphedema is still a little opaque to me. And it's not typically lymphedema that begins early in childhood. These kids aren't born with lymphedema. It typically comes on somewhere in later childhood or adolescence. Can start early, but typically doesn't. So I don't really understand the mechanism except to tell you those things.
All right, we'll give it another minute to see if anybody has some last questions.
One last thing I'd point out is that, one of the critical things that we've been doing recently is to go into these families and to, if you have a family with a mutation affected proband, then go into the family and test everybody else and find all those people who are mutation positive and not symptomatic, to really try and get at this question of penetrance. Because when we only look at people who are eventually symptomatic and we say, oh, this one got symptomatic at 60, this one got symptomatic at 20, that's a slightly different picture than saying, I'm going to go into this family and I'm going to identify all symptomatics, even those, all mutated affecteds, even those who are not symptomatic. And when you do that, it turns out that the penetrance is not as complete as we thought. And so there are some people who get through life with very little in the way of manifestations, which is why I'm a little reluctant to recommend that people get transplanted before they develop symptoms. I can't predict very well who's really going to develop symptoms. I mean, you look at this family and say, wow, those guys have a problem. But I'm still a little by those people who are mutation positive and otherwise healthy. And so in my practice, I like to make sure that they show me a problem before I'm willing to take them to a risk of a transplant. Usually that's infections or malignant changes or, problems like that, refractory cytopenias. Those are all good reasons. But, if you had an asymptomatic 20-year-old who said, well, I got nothing else to do, I'm not working right now, I'd like to get a transplant, I'd be nervous.
All right. Well, with that, I think we can probably wrap it up. Steve, thank you very much. This was great and great insight that I'm sure all of us enjoyed. And so thank you everybody for coming tonight. And we'll end it with that. And everyone have a great rest of the night.
Thank you very much. Thanks, Nick, for letting me join in. Talk to you all later.
Have a good night, everyone.